know this is controversial, but let's think about it. What do you think you can get from being in pain?
Well, sympathy.
But when you change your breathing, and especially when you change it to a slow, relaxed breathing state, what you're doing is you're telling your brain you're okay. You're not being chased by a saber-toothed tiger. That if you are next to a window in hospital, your stay is shorter and you need less pain relief. Can you think of a time where you were put in an unfamiliar environment and it affected your health?
Maybe moving to Singapore.
It was for me.
Yeah.
Welcome back to another episode of the Best of Both Worlds podcast, the ultimate in health conversations, where we look to discuss, consider, and potentially even find the humour in our quest as healthcare practitioners to optimize health and performance. That is sports performance, emotional performance, and just performance in life in general. We hope to learn with you, to share with you, and to create powerful, high-performance lives. I'm Matt Winter, Doctor of Physical Therapy with training in functional medicine, and I am here with Paul McCauley, Senior Podiatrist, otherwise known on TikTok as the legendary Paul the Podiatrist. How was your week, mate?
God, it was a tough week. You know, it was quite stressful towards the end of the week.
Oh, what happened?
Just busy, you know.
Actually, sorry, I'm going to interrupt you there, because we should practice what we preach. And last week I said we should be asking our mates, how are you out of 10? So I'm going to do that again. Mate, how are you out of 10?
Well, yesterday I would have said I'm probably about a 3 out of 10. It's a pretty stressful day.
Why didn't you tell me that?
Well, I told you how I was feeling, but in a different way.
Mate, 3 out of 10's bad. What happened?
Yeah, just lots and lots of patients, colleagues away, lab tech away, putting a lot of pressure on myself. Did a 12-hour day. But last night, got a really good night's sleep, got to bed early, prioritised myself, got up nice and early this morning, hit the cafe, had some me time, did some preparation for the podcast, and now I'd say probably 8 out of 10.
That's a big turnaround. And I walked in this morning for the podcast and the lights were already set up. It was ready to go. I'd done absolutely nothing. So you are on a roll.
Cheers, mate.
Yeah, well done.
Good start.
All right, mate, what have we got coming up?
So today we've got a very special guest.
Have we?
Yeah, he's a specialist in his area, clinical educator, even gave a talk on this specific topic last night. It is the one and only Dr. Matt Winter.
Whew. It's quite an intro. I'll take that. How many people did I do the talk to yesterday?
Well, you said 200. 200 aunties.
Yeah, give or take 100. But So today we are talking about pain.
Yeah.
Which is something that we all experience in clinic, and it's probably something we all experience in life. In fact, I saw a recent stat in Singapore that actually 1 in 10 Singaporeans experience chronic pain at the moment, which is a lot.
That is a lot, yeah.
So what we're going to learn today is that pain is not just about our structure. It's not just about injury. Of course, sometimes it is, but there are so many other things that go in to creating that experience of pain. Mm-hmm. And then we're going to talk about how we can manage that. And we talked about pulling the big levers in the last podcast. And today we're going to be talking about pulling the big levers here in pain. And you're going to find out, and everyone listening is going to find out, that we've got so much power, so much potential control to manage this and get ourselves out of this situation. Actually, before we dive down into it, haven't you got a definition on this?
Yeah, mate. I've done a bit of research. I'm going to give it to you.
Can you just give me the definition instead?
Yeah, of course. It's an unpleasant sensory and emotional experience related to potential or actual tissue damage.
Great. And already in that definition, we've got that word potential, which is so important. And I want for everyone listening to just do a little thing, not if you're driving, but if you're not driving. Pinch your ear. Go on, Paul. Pinch your ear. That's it. Give it a good squeeze. Is that painful?
Bit painful?
Yeah. Did you cause damage?
I hope not.
Probably not. And so already we're getting this idea that you've got this signal which gone to your brain about potential danger, and you're experiencing pain, but without causing damage. So straight away we're seeing that it's not necessarily correlated to tissue damage, and that's what we're going to explore a little bit further.
Yeah.
I'm going to start with a story, if that's all right. Do you like a story?
I do. Don't send me to sleep there, Matt.
I'll do my very best. Okay, so let me set the scene for you. Way back in the dark ages, in the 1990s, 1995, around then, They're really old.
I was a young baby.
I think I was pretty old already. There was a builder, and he was climbing a ladder, and it was in Leicestershire, which is sort of in between where me and you live.
In the Midlands.
In the Midlands, in the UK, in the winter as well, so really miserable, I assume. And he was climbing the ladder, and then he fell off, and he fell onto a nail. And the nail went through all the way through his boot. He was taken kicking and screaming to Leicestershire Royal Infirmary, the main hospital. And the doctors and nurses, they gave him ketamine, a super strong painkiller, and midazolam, a sedative. And when they took the boot off, what they found was, and we'll put a picture of this up on the screen, the nail hadn't gone through his foot at all. It had gone in between his toes. Right?
Yeah.
So no damage. And yet he was in so much pain. And they were so amazed by this that the doctors involved wrote up a very, very small article in the British Medical Journal and published it. And it is a really small article. But I think it says enough. It says enough that straight away, again, structure doesn't equal pain. Mm-hmm. And that's what we're going to build on today. And this really adds up in the rest of the literature as well. A really great study.
Here we go.
The start on the studies.
Of the studies.
If you take a load of people with no pain, no symptoms, chuck them in an MRI scanner and look at their backs, especially when we get into our 40s, you're going to find that up to 75% of them have disc degeneration in their lumbar spines, and I'm talking with no symptoms of pain. Yeah. And once we get all the way up into our 80s, you can make that 100%. And this holds true for other conditions in the back as well, with slightly diminishing returns, even up to like spondylolisthesis, right? So 25% in their 40s will have spondylolisthesis, and it's a big word for something that sounds very scary. But essentially, these people don't have any pain.
Yeah.
Now, the same group of authors, and we'll put a link to this in the...
But that particular study got a lot of media.
It got a lot of media, yeah. It's everywhere. What's important is we don't completely discount structure as well. And it's interesting because the same group of authors that did this study that got loads of attention did another study within roughly the same year. They found that people with back pain actually do have slightly more findings on MRI than people that don't. And I know that sounds confusing now. But what I'm trying to do is find balance here. Understand that structure sometimes relates to pain, but a lot of the time it doesn't, and you can have a terrible looking MRI and no pain. Yeah. So let's like move from that point.
Yeah.
What's going on is that pain as an output is based on many different inputs. Mm-hmm. So let's run through those. The first thing is cognition. So your thoughts, beliefs, what you've been told before about what might be going on.
Is that potentially like how you've been brought up? Like?
Yeah, definitely. So your background and the narratives that you've heard will definitely pay into what you're going to then experience. So, like, what were your parents like when it came to injury, for example?
Oh, it's a long time ago. But I would say there was always the rub it better.
That's a really interesting point, by the way.
Yeah.
What about on rub it better? Because that is a really interesting point.
That's to desensitize the area?
Yeah, that's right. Just so people understand this, when we're experiencing pain, the danger signals that are sent from, let's say, your knee to the spine actually compete with attention at the spinal level, at what we call the dorsal horn, with mechanical receptors.
Yeah.
And so if you rub the knee, you're putting in mechanical stimulation that gets to the spinal level, the same spinal level, and it fights for attention. And if you've got more mechanical stimulation than danger stimulation, that signal doesn't even get to the brain.
Yeah, yeah.
And that's why rub it better really works.
Yeah.
And that's why we use things like TENS in physiotherapy. And then, women that have been given birth, they might be given TENS units.
Yeah.
Might have experienced how well that works. So yeah, that's a great
We've also
point.
used that on like Achilles tendinopathies, rubbing it.
Oh yes, to
to
desensitize the nerve. Yeah,
desensitize it.
yeah. So you often get these sort of hypersensitive nerve endings. Anyway, let's come back to the point. So
Yeah.
it was more about how your parents responded to you when you had an injury. So, for example, I'll talk about my mum then. So there was a famous story for me. Was I was about 12 years old. I come back from a summer camp, and I had a water pistol fight in the garden. Great times. Ran straight into a climbing frame, and I've still got the scar from it right above my eyebrow.
An imperfection.
An imperfection, but I think it creates, in some ways, a perfection. You know, people. What's that line in the song?
I don't know.
It's "You're perfect imperfections." That is John Legend.
Mate,
It is.
he's older than me, that's for sure.
He's my contemporary. So anyway, yeah. So I ran into the climbing frame, got a massive scar, and I remember my mum screaming, "Oh, it's his eye! It's his eye!" And she was going mad. Take him to hospital, and my dad just went, "Calm down, Jack." And of course, like, it wasn't my eye; it was just above my eye. But these kind of experiences, and then my mum got sick a few times in my childhood, and it was missed by doctors, and so for me, every time I get a symptom, I immediately think the worst. So these kind of like childhood experiences have added up, and potentially I think that amplifies my experiences.
Yeah.
So yes, in answer to your question, your childhood experiences are quite formative, and then things that people have told you, your contemporaries, but also the healthcare practitioners you go and see. I think we talked about a study before about how MRIs are explained to you.
Yeah. So within this study, there's two groups of people.
Yeah.
A group where they explain the findings in all scientific terms, and then a group where they're given a reassuring explanation on what the findings are. And actually, what it found was the people who were given the scientific explanation would seen to have more pain than the people who had the reassuring explanation.
Yeah, and it's the power of words, right? And
Yeah.
this is why it's so important to have healthcare practitioners, clinicians that explain things in a non-threatening manner.
Yeah, and I think that's where like our job can become very tiring, because you've really got to think about every single thing that you're saying to someone. You can't just say something like off the bat, which could potentially harm the way that they recover from their injury, that could just go not just on this injury, it could go further and further into their life, and that's something they may always remember.
I think we've talked about words before. If we haven't, there's some great research on this as well, the words we use as healthcare practitioners and what people hear. Didn't you have some research on this?
Yeah. So another study, which I've pulled up. Yeah.
Incredible.
I've learned. So Darlow et al. In 2013. So words that we use and how they're interpreted. So, for example, a word which is on it, which we'll probably use quite a lot today, is chronic. And the people within this study felt that they were 2 steps from a wheelchair from just that word. Instability, which is something which I use a lot.
Yeah, I do as well.
Ankle instability. I suppose you use it like with knee, hips, everything.
Even back, yeah.
So that was seen as liable to pop out. So they feel like, they could have some sort of dislocation.
Yeah.
And then I think the most astounding thing for me was wear and tear, which is often used to describe like arthritis. And doctors, well, from in the UK NHS, short patient clinic time would just say to patients, "Oh, it's just a bit of wear and tear," and that can come out as something is rotting away, which can really worry some people. So it's very interesting on the power of words.
And patients really remember what we've said to them, and they'll pick up on 1 or 2 words, sometimes not always in context as well, and that's why we really have to think about every single word we're using. What I think it's quite nice to use imagery to explain things to them a bit more. Does the study give any suggestions about other words or phrases we can use to explain things?
Yeah, definitely. I think one good one for the wear and tear is that your joints are showing natural and healthy signs of use.
Yeah, I heard one that was where your joints are displaying everywhere you've been and everything you've done in your life.
Yeah, that's a positive one.
Quite nice, isn't it?
Yeah, and then people will be like, "Yeah, I've been a lot of places. Yeah, I've walked a lot," and feel good about it.
I'm like, good on you.
Yeah, rather than wear and tear. Like, what's tearing?
Yeah.
Why is it wearing?
Yeah.
Am I just getting old?
Yeah. But this is something I was going to say at the end, but I think it fits in very well now. Apparently, there's no evidence that older people have any more neck and back pain than younger people, and they might even have less.
Really?
And that goes completely against those MRI findings again, which we clearly accumulate
Yeah.
change in our spines.
Yeah.
And I will say that it is true that older individuals have less neck mobility. 100%. Their mobility is limited, especially in cervical rotation.
Yeah.
But that doesn't necessarily correlate with pain.
Well, because also they'll potentially be less active. So
Yes.
they're not stressing themselves as much.
Yes. That is a bit confounding as a factor.
Yeah. But then the research from 2009 from Singapore was that chronic pain is within, I think it's 9% of the population, but it's 15% of the lower economic, socioeconomic group in Singapore. But what it said is it's likely to increase as Singapore ages. So they're saying that what they're suggesting is that chronic pain is more common in an aging population.
Interesting.
Yeah, but it was from 2009, so...
But I'm just going to withhold comment on that.
Okay.
But it's interesting what you said about socioeconomic class, and I think that goes back into what we were saying about what you hear, and it's also about what you understand.
Yeah.
And that's because understanding and education is so important when when trying to feel empowered about your situation.
Yeah.
If you can accumulate knowledge,
Yeah.
which unfortunately often correlates with socioeconomic status.
Yeah.
Then
Because of lack of access.
access, exactly, then you are empowered, then you feel like you have the power to change things.
Yeah.
And that goes straight back to our cognition, thoughts and beliefs, which is what we were focusing on before.
Yeah.
So let's return to that. We were talking about all the main inputs that might then lead you to experience a modulation in pain.
Yeah. Yeah.
So that's one. Interoception, which is our tissue structure, we understand, we innately understand that if you have an injury or damage to your tissue, that might cause a problem in terms of pain. So I don't need to go into that.
Yeah.
Then where you are in time and space, we would call that proprioception. So are you in a specific position that in the past was threatening to you?
Yeah.
So, as a footballer, potentially, on your stance leg, changing direction, you did your ACL in that position before, you did your MCL, medial collateral ligament.
Yeah.
That's potentially threatening, isn't it? So, and it might even be you were in a walk that you do, or in Singapore, every time you go to McRitchie Reservoir, your knee flares up for some reason, or Bukit Timah Hill, right?
Because it reminds you of that bad experience.
Your brain remembers where you were in time and space. And then there is your five senses. So what you're seeing, what you're hearing, what you're smelling. The really nice way to explain this, actually, is, because it's not always related to pain, it's just related to an output, is have you ever walked past a girl or a boy?
I've walked past some girls, yeah.
Yeah. We talked about that last week. You've seen a lot of fit boys, haven't you, in Singapore?
I've seen a lot of fit boys in the gym.
So have you ever walked past a girl and they're wearing the perfume of a girl that maybe you had a crush on when you were younger, or you dated, or you had like a great relationship with? You're like, ooh, and suddenly this feeling comes back and your heart rate goes up. You maybe get a bit clammy in the hands.
I remember a specific perfume, Daisy, I think by Paco Rabanne. I think it's Paco Rabanne.
Mate, that's probably like the most specific thing I've heard you remember.
Yeah, well, it's not a definition, so it's much easier.
But and then so what you've got there is a smell, so a sensory input related to a memory, which causes an output. And that's actually how neurotags or neural signatures in the brain work related to pain.
Yeah.
Right? So our five senses giving us information, maybe with our proprioception, where we are in time and space, with a memory of a belief or an experience, and then you get an output. And that's exactly how pain output works. Pretty cool, huh?
Nice, very interesting.
Actually, another nice way of explaining this is, do you cook, mate? Do you cook?
Well, not as much as I used to in Singapore. I mean, it's much easier to not cook here. A bit cheaper to eat out, and also I get these food deliveries.
But you are so lazy.
But, mate, don't lie. You also get the deliveries too.
I stitched myself up. Yeah, no, it's true.
But come on.
And the food's too cheap here as well.
Yeah.
And it's full of oil, which is terrible. And we'll talk about that
Tastes
when we
good,
get to
though.
diet and inflammation. But anyway, not just full of oil, but bad. Anyway, I'll come back to that. So anyway, I was cooking, and because I'm not very good, I looked down at my hands while I was cooking, and I noticed there was blood sort of streaming down my hand. Right?
Classic.
So clumsy.
Nice.
But the cool thing about it was, and this is what I realized at the time, I had blood going down my hand, but it hadn't hurt up until that point.
Yeah.
And I saw it and I internalized it, and then it started hurting.
Yeah.
And what that was tissue damage, structural damage, not causing me a problem.
Yeah.
And then visual evidence
Yeah.
of damage.
Yeah.
So my five senses, or one of my five senses, and suddenly, bang, pain.
Yeah.
So I had to reach that threshold of enough credible evidence.
Yeah.
And that is why the researchers who I'm in awe of, really, Dr. Lorimer Moseley, who was a physiotherapist, now neuroscientist, David Butler, also physiotherapist, they head up this group called the Pain Revolution Group. 200 postdoctoral researchers, probably more now, doing great work in this field, and they summarized everything like this. You will have pain when the brain weighs the world around you, and I would add, and within you, and decides that there's more credible evidence of danger in it than safety.
Yeah. Yeah, well, it's interesting. I actually did nail surgery a couple of days ago, and I've numbed the toe off. It's very numb. The bloke's just staring at me doing it, but he wants to watch it, but he's like, "Oh, I think I feel something," and I'm like, "All right, yeah, really?" And actually, he was thinking so much about this should be painful that he felt like he was feeling pain, but yeah, he wasn't feeling any pain.
Were you able to test that?
Yeah, I did the pinch test. So pinched like more near the ankle where he will be able to feel it, and then we're pinching more around the toe and he can't feel anything. So it's good way to do it.
That's really interesting. That's like sort of the well, I think it's almost the opposite of how mirror box therapy works. So there's this cool thing. Maybe we can talk about an exercise. Actually, I'll talk about it now. So when you have like a really painful area. And we get this in like complex regional pain syndrome. Actually, it really occurs in amputees, where there's this phenomena called phantom limb pain, right? And this is where someone's potentially had a very painful limb because of gangrene, like necrosis, things like that, and they've had it amputated. Yeah. And after amputation, they still have pain where that limb was.
Yeah, yeah.
Which is horrific when you think about it. You haven't even got the leg there, and yet you think you have pain there.
Yeah, it must be awful.
How bad is that? Not only have you lost your leg, you've still got pain. So one of the therapies that is done is mirror box therapy, where they they do is they put the good leg into this mirror box.
Yeah.
And then the person looks at, essentially has a look at this mirror box, and their brain sees their other leg.
Yeah.
Right, so they see the previously amputated leg.
Yeah.
And so you move the good leg, and yet the brain perceives the other leg is moving.
Yeah.
And it's fine, and it's painless.
Yeah.
And it starts to down-regulate. And that's what gets them out of pain once the brain sees, oh, actually, I am okay.
Yeah, yeah. Well, that's a similar thing like the patient who I had yesterday, who I was talking about, a basketballer that had a knee injury, I think ACL. And then he told me 6 months ago that he could only train, he couldn't play games. Like, he was just getting too much pain. And he was training sort of 4 or 5 times a week, 2 hours at a time. So he was doing a lot of training, enough to replicate playing in a game. And he was just scared. And I sort of gave him, we talked about all the movements he's been doing in his training. Has he been doing jump shots? Is he doing change of direction? He's doing all those things. And he's feeling no pain. So I said, oh, all right, I think you can play. Just get on the bench, play 10 minutes, and see how that goes. And he came in yesterday and he said that he's been playing for the last 6 months, and it's all thanks to me, is what he said. And all he required was a bit of coaching from maybe someone, a bit older, so a bit more mature and sporty, to say that it's okay.
Well, I'm sure someone that he perceived to be in a place of knowledge as well.
Yeah, maybe.
Yeah.
Yeah.
Don't do yourself a disservice. Yeah, actually, I had a very similar episode yesterday as well. I had a young lady who'd injured her knee. She'd actually fallen on her knee. And actually, we saw this patient together.
Yeah. Oh,
and and she came in and she said she's really struggling with stairs, going up and down stairs. I'm fine. Okay.
This is good.
Yeah. And then I got her to squat, and she could squat fine.
Yeah.
Then I got her to single leg squat,
Yeah.
get up and down off a chair.
Yeah.
On one leg. It's quite
Yeah.
difficult.
Yeah.
Absolutely fine.
Yeah.
No issues at all. And we did some other strength tests as well. Fine. And then I said, right, show me how you are on the stairs. And she did this weird pivot as she came down the stairs. Like
Demo.
really. Demo? Really? I can't do that now.
It's
All right,
okay.
anyway. So she did this weird pivot as she came down the stairs. And it's like, ooh, that hurt a bit.
Yeah.
I said, okay, look, do you remember in the room we did that squat and you were fine? And she's like, yeah. Do you remember we did a single leg squat and you were fine? She's like, yeah. I said, go up those stairs again, and come down those stairs again, and just do it. Just go for it.
Yeah.
And she did it, and she walked down the stairs absolutely fine. She looked at me like I was a genius.
Yeah. Well, you are.
Well,
Dr. Matt.
don't go on about it. And it really was like she had to join those dots that
Yeah.
actually she could do it. And that's why sometimes it's really important to change the context a little bit, change the environment.
Yeah.
Get them to do the movement in another way
Yeah.
to show them they can do it, and then put it back into the movement that they couldn't do prior.
Yeah.
So
It's a really, really good one.
yeah, it's interesting, isn't it? And there we have it. So basically, they conclude more evidence of danger than safety equals pain. Right. Now, the interesting thing is that this danger issue doesn't necessarily just affect our perception of pain, but it also can change how we heal as well. So if we think of sort of danger and stress in a very similar light, I think they're quite similar.
Yeah.
We talked about it a little bit before in the last podcast, but that stress itself can actually impact healing.
Yeah.
And we talked about the study that when you're in a stressful situation, they actually looked at married couples for this.
Is it always stressful?
Sorry?
Is it always stressful?
Well, I'm not even married. I can't even tell you.
I've heard from some that it is.
Some people say it is.
Yeah.
Some people say it's beautiful and
Yeah.
wonderful. But if a married couple, super stressed out over a period of a week, a wound that actually the investigators inflicted on them heals 40% slower.
Yeah.
In fact, what they found was that genetically 100 genes are switched off in
Yeah.
related to healing. We went through this before, and we enter into this more inflammatory state.
Yeah.
Now, what we didn't talk about were mice, right? So actually, animals are affected in a very similar way. Now, if you take a mouse, take a mouse, if you take a mouse, and you give it a little electric shock
Yeah.
in an unfamiliar environment.
Mm-hmm.
Interleukin-1. Oh, we did talk about this.
No, we didn't talk about the mice though. But we did talk about interleukins.
Oh, we did.
But
Okay.
it's just briefly, you were just telling me about.
Well, interleukin-1 is a marker of inflammation.
Yeah.
And interleukin-1 spikes when they get this electric shock in an unfamiliar environment. But when you put them in their own house, in a familiar environment, you don't get that.
Yeah.
No response.
Not worried.
No, not bothered.
Yeah.
So the environment really cued for the response.
Yeah.
Interesting, isn't it?
It is interesting. Yeah.
Can you think of a time where you were put in an unfamiliar environment and it affected your health?
Maybe moving to Singapore.
It was for me.
Yeah. Well, I put on 2 kilos in 2 weeks.
That's cortisol
Yeah.
causing fat storage. So your body's under stress.
It wasn't the vast amount of chicken rice that I consumed.
Not at all. But your body is storing that because it's worried,
Yeah. Yeah. Yeah.
right? So for me, when I came here, the amount of investigations I ended up having, unbelievable. And I came here with 3 other friends.
Yeah.
One was actually had an MRI of his brain and told he either had multiple sclerosis or a brain tumor, and called his parents.
Which ones you got?
Neither. so there you go.
Problem.
Great example of
Parents
clinicians
probably well
sort of
worried.
scaring the hell out of you for
Yeah.
no reason. My other friend had a CT angiogram because worried about her heart.
Yeah.
I mean, I had like 3 or 4 different MRIs and so I think I saw most of the specialists at Tantoxane.
Yeah. Is that how you built your connections?
Absolutely.
Yeah.
So always thinking, networking. But that's it. You see, you put yourself in an unfamiliar environment, and it is scary to your body.
Yeah.
Everything changes. Nutritionally, your microbiomes is shot. Different weather. All of this is potentially danger-inducing. Yeah. Look, just to recap. So where we're at the moment is right. Pain is not necessarily related to structural damage, although sometimes it can be. It's very much related to everything around us: our beliefs, our thoughts, where we are in time and space, and that sometimes those same factors can impact not just pain but healing as well. I started to understand this and progressively understand this over my sort of first 10, 15 years of practice, and realized it's really
Bloody
hard
hell, you're old.
Mate, honestly, I am.
Yeah, those greys are real.
Can you see them on the camera?
No, you can't see them on the camera.
Great, good. But I also realised it's really hard as a healthcare practitioner to integrate all the research into how we treat people, and it's hard for patients to then know what to do. So it's all very well saying this,
Yeah.
but then what do you do about it? It's quite hard. So this is why I decided to come up with this safe approach, A, B, C, D, E, S's of managing pain.
S's or Z's.
What it's S's.
Then there's a S, like a snake.
God.
God,
Right,
these southerners.
So the safe approach, A to E's, is actually used a lot in pre-hospital care.
Yeah.
Where we really benefit from these structures. So essentially I put together this sort of paradigm, this SABCDE, right? And S, as it does in pre-hospital care when we teach this, stands for safety and safe approach. Now, as clinicians, we can create safety in how we present ourselves, in the environment. So this clinic here is not like, I don't think, a typical clinic. So there's no white walls, or very little white walls.
What about my NHS room?
Apart from your NHS room, which
No
is
windows.
cold and white, no
Cold.
windows.
And the artwork.
Yeah, it's terrible. Okay, well, in my rooms, anyway.
Your room's cool, though.
Lovely, isn't it?
Yeah, and the wooden doors.
Exactly. So we've got wooden doors, we've got blue walls, which is where we're filming here.
Yeah.
Lots of wood.
Feels like a spa.
It's a bit much. It feels like a cafe. I think it feels like a cafe in the
Okay.
waiting room, and then we've got the gym space, which is a lot brighter.
Yeah.
So actually, right, I went to a conference when I was 21, so the geekdom had started even there.
I'm surprised you can even remember that far.
Well done, mate. So, and in this the conference was called Medicine as if People Matter. Great title, right? Because it depends where you put the comma. Like you can go medicine as if people matter, or medicine as if people matter. What it was all about, all the things that contribute to patients getting better that we don't normally think of. So, for example, the design of hospitals. And there was this one guy that got up and spoke about this hospital that he designed and created that had no ends to the corridors. It was all sort of circular and soft. And then huge windows, lots of gardens, and the staff wore all like their more relaxed clothing, not typical healthcare uniforms.
Yeah.
Patients did really, really well.
Yeah.
And it aligns with research that shows that if you are next to a window in hospital, your stay is shorter and you need less pain relief. So if you're ever hospitalized, get that window seat.
Yeah.
That is what you need. Really important for mental health, and probably clearly does affect pain.
Yeah. Yeah.
But the UK is so rubbish at that.
Yeah.
Oh,
Well,
so
all
miserable.
the
little
NHS just reminds me of like rooms without windows. Some dingy, like a placement in like some sort of war memorial hospital, which the name suggests it's old.
Yeah.
You know, the heating doesn't work properly. The hallways are like this horrible like green colour. The floors like old.
And they always smell the same as well, that
Yeah.
awful antiseptic smell.
Yeah. Yeah,
Why
where-
are the corridors always green?
Whereas
That's a
here,
light green.
You go to Mount E. I mean, maybe not the whole layout, but the smell of it smells good.
Smells nice,
Yeah.
doesn't it? Mount E, not the great one. I think so. I worked at Tan Tock Seng here.
Yeah.
And they've got this lovely. You walk in, it's like got a nice fountain, it's got a food court. When my parents came to visit, they thought it was like a hotel. Showed them around, and then Kutek Point Hospital here. They put loads of effort into like having more greenery.
Yeah.
Even into staff well-being. It's great. It's great. Look, I think it really impacts how people feel.
Yeah.
Anyway, we digress slightly, but so safe approach. This is how we create safety in our patients, right?
Yeah.
How can we create safety in our life?
Yeah.
So the friends we surround ourselves with, we talked about society and sort of community, how important that is.
Yeah.
Not necessarily, we can't choose our families necessarily, but how we interact with them and how we create boundaries potentially. And the healthcare practitioners we choose to see.
Yeah.
So important how people explain what's going on with us.
Yeah.
What the language they used, are they inducing fear, catastrophization, things like that. So
Yeah. And
this,
matching up that healthcare practitioner to that patient. Yeah, you're not going to be the perfect healthcare practitioner for every patient.
But I agree that it is important to match people, and I fully accept now, and it's taken me a while to accept this, that I'm not going to be right for everyone.
Yeah.
And it's just important that you do, as much as I know that we both really try to adapt our communication styles to the patient accordingly. But you're not always going to be right, and I accept that people might go somewhere else, and because that connection is so important to form that therapeutic alliance that gets people better.
Yeah, for sure.
So we need to create as much safety in me. They're called SIMs in the research, and avoid the DIMs, the dangers in me, and work around those at least acknowledge them as contributors. So that's our safe approach, and then we move on to A, awareness. If you are not self-aware, you are never going to make change. So the first thing I try and do with my patients is to get them to be aware of themselves.
Yeah.
And that is how they're responding to their environment. What are their habits?
Yeah.
How do they respond to stress?
Yeah.
Is there a heart rate response? Is there a postural response? Do they become more sedentary?
Yeah.
Do they change their postures to reflect that? We know that when we're under threat, we tend to go a bit more fetal position. Do they eat more? Do they have, I think you spoke last time about unhealthy habits. Do they smoke or drink more?
Yeah.
But unless you have this internal awareness, you're never going to be able to then change those things.
Yeah. Yeah, and like it's better to come to that conclusion yourself than be told it by somebody else.
Yeah. So I think what we can do is ask questions.
Yeah.
Do you know how you respond to stress?
Do I know?
Yeah.
Okay. The heart rate will go up. Yeah. And I can feel it in my shoulders and my neck. Like I won't go to the gym. And that's more because I prioritize my sleep. So I always go to the gym in the morning. So I prioritize my sleep to try to.
Is it that, or is it that your mood doesn't allow you to get out of bed? I'm just throwing that out there.
So I still get out of bed early, but I just
you do other things.
I do other things which will help settle my mind down.
That's okay. That's very reflective in a positive way.
It's only happened in sort of, I would say, the last year. I've made those changes because often I think I've got these things I want to tick off my list all the time, all these things I want to do. So I put this added pressure on myself. So I try to remove those pressures and then just focus on the main thing which is causing the stress, which is often work. So I focus on getting things done for that rather than going to the gym.
That's so important. That's such a good point. I can't remember. I heard another reel on online. There are people putting good content out there that stress is just a reflection of lack of action or something like that. And actually, if you're in action and you're addressing the things you need to address, your stress really comes down a lot.
Yeah.
It's a really interesting point.
Well, there's a great book called Eat That Frog.
Right.
I was made to read it when I first joined my first company out of uni.
Is it the French book?
No, it's not. It's not. But it's a great book because it talks about how you should do the task which you least want to do. You should do it first. So eat that frog, get it done, and then it makes every other task easier. Whereas if you don't do that hard task first, you'll never do that task. And then eventually it'll come back to bite you.
Yeah.
Your boss will say, Paul, where's that thing from 3 weeks ago? And you won't have done it.
But you've done everything else, but that doesn't matter because you haven't done the real big thing. It's like when you're a kid, just eat the broccoli first, and then you can move on to the
Yorkshire
chicken.
pudding.
Yeah, or the Yorkshire pudding. What are we talking about? Pain. Oh, awareness, right? Yeah. Self-awareness, right? So now we've brought this awareness to ourselves of how we respond to stresses. Actually, I see it in you. You get really red in the face, don't you, when you're getting stressed and pumped up? Yeah. Then we can start to intervene, and that brings us on to B, which is breathing. And it sounds so simple, but when you change your breathing, what you're doing, especially when you change it to a slow, relaxed breathing state, what you're doing is you're telling your brain you're okay. You're not being chased by a saber-toothed tiger. Actually, I want everyone to do this right now. Take a deep breath in, hold it, sniff in again, and then slowly breathe out. That's nice. Do you feel better?
Good.
It's good, isn't it?
Yeah.
Now I've taken that directly from Andrew Huberman in his podcast, so not to that, but his group at Stanford University that looked at this method of cyclic sighing with great effects on putting people out of their fight or flight nervous system into their parasympathetic rest, digest, recover part of the nervous system. But the cool thing is when you do that, not only are you lowering your heart rate, lowering your blood pressure, you also change the pH in your blood. So you actually come into a less acidic state. And we didn't really dive down into this, but one of the receptors that you have in your body is chemoreceptors. They measure the chemical makeup of that tissue, and they're sensitive to pH changes. So when you change your pH to a better environment, there's less danger signals going to the brain, less pain, just from breathing.
Yeah, amazing.
Yeah.
I'm gonna have to try that next time I get red in the face.
Yeah.
You know, you should actually tell me because
I will.
as well. Yeah.
What it's like 8 times a day.
Only on Fridays.
Okay, so breathing is a really, really good way to intervene. Actually, can I tell a personal story on this? I actually suffered from anxiety for a while, and I might come across as fairly confident, I think, but there was a time in my life when I really, really struggled. And it all began from a very innocuous comment from one of my colleagues who said, "Oh, Matt, you'd be really pleased to know that I stuck up for you today." Because in the staff room, they were talking about you rotating down to outpatients from respiratory, which is where I was before. And someone said, "Oh, God, he's really arrogant." And I said, "Yeah, can you believe it?"
Unbelievable.
Unbelievable. And
I didn't know you when you were young because I was still at school.
yeah, okay, mate, you are on a roll today, aren't you?
On fire.
And she said, "But don't worry, I said that you're a great physio, and you know, if I was a patient, I'd want you to be my physio." And I thought, well, that's nice. But now I just think I'm going to be absolutely hated when I go down there. And as soon as I walked into that environment, hey, this is another good example of this neurotag. As soon as I walked into the environment, I had to get up and introduce myself, and I felt my face flush, my skin, I got really sweaty, and I just felt like I was hated. And it was a really bright light when I was introducing myself. And from that point onwards, every time I walked into a bright light, I got the same physiological response. And then it just translated into me being generally anxious.
Yeah.
And I couldn't shift it for years until I suddenly remembered the CBT approach to managing pain or interrupted function.
Yeah.
And if you can't intervene through your thoughts, your cognition, you can intervene through your behaviors. And I was reminded of this, and I thought, okay, if I just become aware of how my breathing is changing and my pulse, maybe I can change that. And when I focused on that for about 2 weeks, everything started to change.
Yeah.
And I started to break that cycle.
Yeah.
And that's why breathing is so important.
Yeah. Nice, fantastic story.
Thanks, mate.
I think we need to.
Bit vulnerable there. All right, C, create change. This is really, really cool. Okay, so the cool thing is, but also slightly depressing, by the age of 30, coming up, happy birthday.
3 weeks.
3 weeks' time. By the age of 30, 90% of your 70,000 thoughts that you have a day are the same.
Wow.
You might have noticed that when you wake up from your sleep in the morning and you think, oh, God. And you click snooze in your alarm for the 3rd time. So all
I never snooze.
Do you not?
Never.
That's great. That's such a good thing.
Roll out of bed straight away.
That's amazing.
Cat gets a bit annoyed.
It's important though.
Yeah.
Not the cat. That's your girlfriend cat.
Yeah.
Yeah.
The cat. Well, the cat. If the cat liked me, the cat would be annoyed.
The cat
too.
would be annoyed. Yeah. The same. And the problem with that is, the more you have those same thoughts, the more the nerve cells fire together. And when nerve cells fire together, they wire together. And that is exactly how sort of patterns related to pain outputs get strengthened as well. So if you're constantly, so every time you walk up, say, Booker T Mile Hill, and you get knee pain, and you think, oh, God, I'm going to end up in a wheelchair. And worst case scenario, right?
Yeah.
Every time you walk up that hill, you're more likely to get knee pain and think, I'm going to end up in a wheelchair. The whole thing happens together.
Yeah.
And so the only way to break that is to change your thoughts, potentially.
Or don't walk up Booker T Hill.
Exactly, change your behaviors. That's right. Because the same thoughts lead to the same feelings.
Yeah.
Can I have that again? The same thoughts lead to the same choices. and the same choices lead to the same actions and behaviors. And those behaviors often lead to the same feelings, and that creates your reality. And Joe Dispenza puts that really well. So you can either change your thoughts, or I believe you can change your behaviors as well to interrupt that cycle. And when you start to do that, you start to feel differently because of the choices you've made. And again, then your thoughts change again. And the really cool thing is this: when you start to think then differently, your genetics start to express differently, and you actually become a different person. And potentially, in that different person, there is no disease or there is no pain.
Yeah.
How cool is that?
That's very cool. And it's like creating habit again, isn't it?
Yeah, that Atomic Habits reference from last time.
Yeah.
Yeah, so just making small changes progressively.
Yeah.
And that is one of the things we can talk about, right? So it doesn't necessarily have to be you completely change who you are.
Yeah.
Although that would be amazing as well. But something more sustainable would be like, your 1% difference a day analogy from last time.
And because the pain can take over your life, can't it? It can, and in the way of like you become that person in pain.
Yes, you embody pain.
Yeah.
And some people would even say, and actually Adam, my mate who we reference all the time, would actually say, how is that serving you?
Yeah.
It's a really tough question to ask someone who's in pain, and I very, very rarely do this. But for some people, it might be worth reflecting on, how is it serving you?
Yeah.
What do you get from being in pain?
Yeah.
I know this is controversial, but let's think about it. What do you think you can get from being in pain?
Well, sympathy.
Yep. Love.
You can get out doing chores.
Yep.
Days off work.
Yep. Attention.
Yeah.
Meaning, potentially. You're that person. Identity.
Yeah.
Care. Lots of great things happen from it, potentially. And some people are scared, if I'm not that person in pain anymore, who am I?
Yeah.
So how can you create a new identity that's not around that?
Yeah.
And that's really scary, coming out of a cared for role.
Yeah.
Back into I don't want to say giving member, but back into a more active member of society.
Yeah.
Yeah, it's tough.
Yeah.
It's good to acknowledge
Very
that.
interesting though.
On a less heavy level, creating change is really important just in our day-to-day lives in terms of, like, say, postures, for example.
Yeah.
People often ask me, what's the right posture?
Yeah.
And I always say there's not one right posture. Sometimes there is good ones. So, for example, I like the gangster pose. For anyone that can't see me right now, I'm doing a ridiculously old-fashioned gangster pose. But
so
sitting back,
Yeah.
tilting back through your pelvis, opening up your hips. Great for hip pain.
Yeah.
Terrible potentially for back pain.
Yeah.
Whereas sitting up for your back pain can be really good, but it's not great for your hips if you've got anterior hip pain. But the most important thing is changing your posture regularly, and that's why I always say your best posture is your next posture.
Nice.
Nice one,
Like
isn't it?
Yeah.
Yeah. So we see that loads in the literature. It's just being static's the worst thing for you.
Yeah. Movement breaks.
What?
That's why I talk about movement breaks.
Movement breaks. Yeah, movement snacks. Nice way of putting it as well.
Okay.
Yeah.
Stacks.
Yeah, snacks, not stacks.
Oh.
Yeah.
So yeah.
Now, I've got to tell you this story very quickly.
But surely that would just lend to movement snacks.
Eating.
You're just gonna get up, move to the fridge, and then snack.
But at least you've moved to the fridge.
True, but then what are you taking from the fridge?
Well, that's your choices, isn't it?
Yeah.
Yeah. So Helen Langer, researcher at Harvard University, she took a group, I think 22 older men in their 70s, right? This is such a cool bit of research. Yeah. And half of them, for a week, they sort of discussed being younger and what they did in their past. The other half, she took them to a monastery for some reason, and then she played music of the time. They read literature of times earlier, like 22 years before. They played games from before, and she took a load of data from them. So, like their height, weight, vision, their mental acuity, and at the end of the week, she remeasured it. Now, the people that had actually indulged in these behaviors of the past, they'd literally immersed themselves in being 22 years younger. They literally got younger. Their mental acuity improved. They became more active. Some of them didn't need a stick, and when they came in, they needed a stick. Literally, some of their vision actually improved because they had indulged in behavior that was of a different age. They therefore thought differently, and their body became that younger person.
Yep.
They literally changed their genetic expression. That is mental, and that just goes to show what you can do when you completely immerse yourself in becoming a new person.
Yeah, that's so cool. Really cool.
Next one is D, diet. One of our favourite topics.
Yep. Love a bit of diet.
There was a recent paper for physiotherapists, and it was called A Call to Action for Physiotherapists. And the call to action was, we need to be discussing nutrition with our patients.
Yeah.
How bad is our training in nutrition?
Well, like I said, I even mentioned on the last episode that we barely get any training, and it would be amazing for us as podiatrists. We treat a lot of diabetics, and just having that conversation about nutrition, diet with your patients would be good.
I think it's unbelievable that you as podiatrists do not get training in nutrition.
Yeah.
When like wound care, especially for diabetics, is so much about that.
Yeah, exactly. I know. It is shocking. So.
I think it is a shocker. And as physios, it's so related to pain as well. We know that obesity is related to increased chance of pain.
Yeah.
But not just because of the axial load, but because fat is, can't even say it, because fat is pro-inflammatory.
Yeah.
Why aren't we learning about this? And it's the same with doctors. They get zero, very, very, very little nutrition training. Very little. So we need to start changing that. Anyway, in this paper, they basically gave 7 tips, and we can maybe put a link to this paper down below. But some of the really interesting, like easy ones to implement, just to understand that 80% of our joints are water.
Yeah.
If you're not hydrating, how are you maintaining that fluid balance within the joint?
Yeah.
So just hydrate.
Yeah.
And I would say for sportsmen, especially in Singapore,
Yeah.
make sure you're hydrating with electrolytes.
Yeah.
We see loads of cases in the Singapore marathon stand chart of overhydration causing hyponatremia, so lack of salt balance.
Yeah.
And that can lead to horrific things like heart attacks.
Is that why? Have you seen that trend on Instagram where there's all these like runner influencers, and they're like, "Oh, I'm just getting my salt in." They're just grabbing salt, putting it. Sorry, just what I just did.
You all right, mate?
Yeah, just putting the salt in their mouth,
Yeah.
and then they're like, "Oh, just getting my salt."
Probably, yeah.
See, oh, it's disgraceful. Like, would you want to eat like that much salt? Just put it in your water.
That sounds awful.
Yeah, yeah. They're just like eating the salt.
It's bizarre.
It's gross. It's gross.
I don't understand what's happening to people. But anyway, yeah, that probably is where it's coming from. So you need to get your electrolytes in and your water. So hydration is really important. Eat plants, loads of beneficial anti-inflammatory compounds, colourful foods, eat the rainbow. You know that. Now, this is quite cool, actually. People think you just have to eat very bright coloured foods. But it's the concept that each colour brings a different benefit. And I'm not going to go into all the details of it now, mostly because I don't know all the details of it. But also, but for flavonoids in berries, right, they do a certain thing.
Yeah.
But there's arguments even that some of the foods that are white, like tofu, have specific properties that have specific benefits.
Yeah.
So it's just about getting that variation in the diet.
Well, my top tip to people for getting the right sort of nutrition would be when they go to the shop, is just to shop from the outside of the shop.
Yeah, that's it.
Getting your fruit and veg, and like not going into that middle section where you're gonna find a lot of processed
Absolutely.
stuff.
Stick to the outside aisles,
Yeah.
100%. Eat good fats, so omega-3 fatty acids, olive oil, cold water fish, mackerel, salmon. We've already said olive oil. Some avocado.
Yeah.
So they help to balance that inflammatory environment. So we're very heavy on omega-6 and 9s these days. You need to get the 3s to get that balance of omega-3, 6 and 9s, which maintain the environment. And consider food intolerances. Often lactose intolerance is super common in Southeast Asia.
Yeah.
And that kind of potential, like that reaction to that food sensitivity can cause this sort of inflammatory response. And there is a relationship between that and chronic pain states. Yeah. And it can be lactose, it could be artificial sweeteners, it could be loads of things. Yeah. And then just maintaining a healthy weight. And I've left a couple, but have a look at the link in there. Education. That is what we're doing now.
Yeah. I think it's really important for us to do this podcast because we talked about that segment of chronic people in Singapore with chronic pain. It's higher in that lower social economical class. So if we can give this education now for free, then they can hopefully access it. And that's why we're pushing out heavily on social media, on TikTok, YouTube, Instagram, so that we can hit as many people as possible.
Yeah, I think gone are the days where, you had to go and do formal education to be really empowered.
Yeah.
Which is great.
Yeah.
Accessibility is great. So just understanding how pain works can be enough sometimes to get you out of pain or to significantly reduce that.
Yeah.
And there's again, maybe we can illustrate this, a study done where they took a dancer who had lower back pain, put her in a functional MRI machine. The top image shows her at rest.
Yeah.
The second image shows her brain lighting up when she was asked to arch her back in the MRI scanner.
Yeah.
And the third image is after half an hour of pain education, being asked to do the same movement.
Yeah.
Look how the brain is completely different.
Yeah. Amazing.
It is incredible.
Yeah.
So that's what we're doing here. The other E is exercise. We've talked about exercise before.
Yep.
But movement itself is one of the greatest modulators of pain. Again, telling the brain you're okay.
Yeah.
And you just have to find the movement that is pain-free. And I can't stress that enough. It's not no pain, no gain.
Yeah.
Unless in specific circumstances it can be, like in specific tendon disorders.
Yeah.
But for example, in knee pain, as soon as you experience pain in the knee, your quad, your VMO shuts down.
Yeah.
No point exercising with knee pain.
Yeah.
Find a way around it.
Yeah.
So that's one thing. Second thing is strength training.
Yeah. We love it.
We love strength training.
Yeah.
Um,
Look at those biceps bulging.
oh,
Matt, before every podcast, always does a workout.
That's not true. that's not true. It is true.
That was true last time, but
It was
this
true
time.
last time, yeah. You stitched me up today. You stitched me up rotten.
Yeah, well, you've been presenting, and I've been thinking about witty
How
comments.
to bring me down.
Yeah.
It's fair. It's fair.
So in a
Fair,
few
fair.
weeks' time, I'll be 30. You can just rip me to shreds.
I can't wait for that, honestly. Yeah. So exercise, so strength training, we talked about it before, what it does. Muscle is an endocrine organ, a signaling organ, signaling for health, bone density, longevity. We know that grip strength at middle age predicts longevity. We know that grip strength and single leg balance even correlates with all the biomarkers of aging in your 30s. If we look at the markers of health, according to the American Council on Aging, 5 of them are related to structure or fitness in some way. Muscle mass, strength, bone density, body composition, and aerobic fitness. When are they ever tested at your annual health checkup?
Yeah. Never.
Never.
Rarely.
Almost never.
Yeah. I think only if you go into like very premium longevity clinics.
Exactly, but it doesn't have to be a premium. You can get a DEXA scan fairly affordably now.
Yeah.
You can do strength testing with dynamometry. We do it in the clinic. There are functional tests you can do, so the others include things like hemodynamics, blood pressure, blood lipid levels. We're doing these.
Yeah.
So maybe you should be seeing a physio and a GP for your annual health check, for example.
Yeah.
And they really correlate with aging, and we know that strength is so important, not just to prevent aging, but also to prevent falls as we age.
Yeah.
If you fall down, fracture your hip,
Then,
over 65,
Yes.
chance of death in a year, 30%.
Yeah.
It's huge.
Yeah, exactly.
Strength training also reverses genetics. It changes our genes. And Simon Melov did this at the Institute of Healthy Aging. He found that if you put over 65s in a strength training protocol twice a week, that over a period of months, over 100, I think it was 175 genes, will reverse to their youthful state.
Yes, Mum and Dad, hope you're watching this because I've been telling you, banging on about strength training for months now. It's meant to be a New Year's resolution. It's nearly February, and I know you haven't booked in with that PT yet.
That's great. That's so important that we hold our parents accountable. My mum just had her first induction at the gym this week, and she's 67. But the funny thing is, she's a fitness instructor. Well, she still is actually. And yet, as she's got older, she's just fallen into that same trap of just thinking, oh, now I'm just going to do some mobility, go for a walk. And she's like, oh, now my knees hurt, my joints hurt. I was like, Mum, please get into the gym, lift heavy weights slowly, progressively. It's the best thing you can do, and eat protein to supplement that. It's really important that we keep our parents accountable. Well done, mate.
Yeah, thanks.
Yeah, good call to action.
Yeah, well, now I just need to try and get them there.
Yeah.
I've contacted the PT, I've given them the number, and it's all there for them to do. But
They've got to want to do it.
Sorry,
They've got to wanna do it.
we're very busy.
So maybe you can use the atomic habits approach, like just get them to do 5 minutes a day at home.
Yeah.
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 Okay. So that's strength training, or exercise, and we move on to the S's. Smoking, just don't do it.
Yeah.
But if you are doing it, you got to change that gradually, because when you stop smoking, actually you can experience more pain.
Yeah.
In many ways, mentally as well. So do it with the supervision of a professional that can help you with ways to do that.
Yeah.
Good. But yeah, don't smoke.
Yeah.
Horrific for pain processing and healing. Sleep. As we spoke about last time, there's this well-established, when you sleep worse, you're more likely to experience pain.
Yeah.
When you sleep better, you're more likely to recover.
Yeah.
And I said I was going to go through some more tips this time, so I'm going to do that a bit more in detail.
Yeah.
We already said keep your bedroom for sleep and sex.
Yeah.
We didn't talk about anything much more than that, so here they are. We want to keep that bedroom dark.
Yeah.
It's really important to get that signal of darkness, to get that melatonin release, get you to sleep. We want to keep it cool. Can I say my colleague? No, not my colleague. Sort of.
Friend.
Anyway, he went to my university.
Yeah.
Matt Walker. Some people say he looks a bit like me. I'm a bit annoyed about that.
Matt Winter, Matt Walker.
Similar, isn't
Same
it?
bloke.
Yeah. He's got more of an accent like yours, though. Great guy. Done a lot of research on sleep. And he says that it's actually really useful to get your core body temperature down in order to sleep. And one of the best ways to do that, ironically, is to heat yourself up before you sleep. So have a hot shower, and then your body tries to cool you by vasodilating at the peripheries. And so you drop your core temperature. And actually what they did in the research was they put gloves and socks on these insomniacs, people that couldn't sleep very well, and found their core temperature dropped and they slept better. So you heat to cool, and then keep your room cool.
Yeah. Nice.
Wi-Fi can potentially be interpreted as light by the brain. So it interrupts our sleep. So there's some suggestions that we should be turning off our Wi-Fi in the house, or at least getting that router really far away and turning off your electronic devices. And if you can't sleep, we talked about this last week, get up and move around. The context forms the cue. As soon as your brain starts interpreting your room as somewhere where you don't sleep well, you're not going to sleep well.
Yeah.
And there's lots more. And the Institute of Functional Medicine have a great handout on this. It's actually quite lengthy.
Shall I put a link to it?
Yeah, put a link to it.
Yeah.
Yeah, it's decent. But yeah, it's really important that we deal with sleep, because if we look at some of the key predictors now, and this was done in 2021, this paper, if you group a whole load of people with chronic pain together and you want to decide who's going to do the worst, all you have to look at is sleep, obesity, and expectation of recovery, a little bit of socioeconomics, and you can work out from that who's going to do the worst.
Wow.
So really, it's everything, right? Pain is everything. In that it can be your structure, it can be your biochemical environment, it can be a little bit your postures, especially your time spent in postures. It can be your hormones. We didn't really talk about that, but we are going to be talking about that next week, in a couple of weeks' time.
Yeah.
A couple of episodes' time. But then it's your environment, where you are in time and space, your beliefs, your cognition. It's all of those things. But at the end of the day, what we're trying to create is a safe environment internally and externally for our bodies. And that is the way that you're going to start to take yourself out of pain or prevent pain in the future.
Yeah. Fantastic. Thank you, Dr. Matt.
Oh, that was good. That was good. That was therapeutic. I
Yeah.
didn't mind doing that for the second time in 2 days. I
Yeah.
enjoyed that.
Yeah, it's very good. So I think now we should move on to a couple of pretty good segments. Our pet peeves, which are pet peeves of our professions.
Yeah.
And then we'll be moving on to our favourite segment, the Magic One segment.
Not like that.
Makes me chuckle every time.
Good, isn't it?
Yeah, it's good.
Right.
So we'll start with our pet peeves. So my pet peeve is for often the way that surgery is introduced to patients. So the way it's like worded to them, sort of suggesting that surgery is the only way that they're going to really get better. And then if a patient's like, oh, I'm not sure I really want surgery, then they're told, oh, well, you could try physio or you could try podiatry, but sort of still with that feeling of that the surgery is really going to be the only thing that benefits them. And that way, then, as we've discussed throughout this podcast, is that the way you've communicated to them is already putting them like back a step, that they're probably already thinking that it's not going to help. And whereas if it was labelled in like, yeah, go see the podiatrist, it's helped really well with lots of other patients before, or see the physio, he's a really great guy, can really definitely help you with this condition, then they're more likely to have a positive result. So I think that would be my pet peeve.
That's brilliant. And it really links into what we were saying today.
Yeah.
Good
All
one.
right, Matt, tell me yours.
Right. Mine is...
Have you lost your voice yet?
Almost. You said that almost hopefully. Okay, so mine is when patients come to me and they say they've been told to strengthen their glutes, they've got weak glutes. And then I ask them, like, that was based on what? And they don't know. And it's not the problem with the patient, it's where us as clinicians, and it's this fad that we have at the moment. It used to be that everyone has a weak core. Now everyone has weak glutes. And it's like, has that been assessed? And I think it's very, very potentially valid that people have weak glutes, but please test it. Do some kind of examination where it's dynamometry testing, a specific movement test, a functional movement, something, because not everyone has weak glutes, and it's not now the cause of everyone's back pain or foot pain or knee pain. So yes, and also there's different types of glutes as well. So is it your glute med that's weak, which does a pretty different thing to what your glute max does, so it needs to be tested in different ranges. So yeah, not everyone has weak glutes, and if you do, make sure it's tested in different ranges to isolate which one is actually weak.
Nice, Matt. I like that.
Thanks.
Shall we move on to our favourite segment?
The
Magic
Magic
One segment. Not like that.
Yeah, you first again?
Oh, thank you. Thank you. So mine is, the one wish for our population group is that everybody learns to tie their laces. And I don't just see this in kids, I also see this in adults. People like to slip their shoes on, break down the back of the shoes, wear their shoes very loosely. And there's a reason our shoes have laces. It is to lock our feet in. If we don't lock our feet in, we're at risk of spraining the ankle. It also adjusts the way the shoe loads on your foot and can put stresses on different structures of your lower limb, which we don't want. And also just not being able to tie your lace at 15, 16 years old, it's something you should have been taught from a very young age. There's YouTubes on it. You can watch YouTube short on it. You can watch a reel on it. It's easy to do. So please, please learn to tie your laces properly.
Hey, I've learned to tie my laces as well, haven't I?
Yeah, it's the first time I've ever seen Matt tie his laces in these shoes.
Right, because you mentioned this before to me, but I did think I looked cool without my laces tied.
Yeah, you're too old for that.
I know. I was trying to be a bit Gen Z, but you know what? You're right. And I was starting to get a bit of like foot discomfort, and I thought it's not worth it, is it?
Yeah. And how are they feeling now?
Better. A lot better.
Yeah, that's good.
So
That's
thanks for that.
All right.
Right, my magic wand.
You're up.
My magic wand is strength training, because I spoke about it then. I want everyone to strength train, push heavy weights progressively, slowly, to fatigue or close to 2 or 3 times a week. That's it.
Love it. So,
Short and sweet.
nice. We made it.
We did it again.
Yeah.
End of episode 2.
Yeah, fantastic.
So, thanks a lot for joining us on our collaborative health journey in reducing pain and increasing health and performance.
Please do hit the like button, subscribe, and please put in the comments anything that you would like to see from us in the future.
We've got a special guest coming up next week, which we will keep a secret for now.
Very exciting.
Until then, strength train and do up your shoelaces. Take care.